Afternoon, everyone, and welcome to our weekly Gecko sessions hosted by the Gastro Foundation of Sub-Saharan Africa and in association with Project ECHO at the University of New Mexico. Um, uh, we've had 86 registrations from this week from 14 countries, so it's a great pleasure to welcome you all. This week's session is devoted to an interesting subject, and that's the adverse effects that have been noted with the checkpoint inhibitors. And our two speakers this afternoon, the first will be an introduction to the issue by Bilal Bobat, who needs really no introduction, a gastroenterologist at the Wits Donald Gordon Medical Center. And our second speaker will be Jonathan Bolon, who is a Wits graduate, spent a year in Oxford at the Radcliffe, working in the IBD unit, who is now a gastroenterologist at the Morningside Mediclinic in Sandton in Johannesburg. So it's a great pleasure to welcome you both. The chat sessions will be open for questions, so please feel free to post your questions, and I'll hand over to Bilal.
Thank you, Chris. Thank you, everybody. I'm just going to start my presentation. You guys can all see that? All right.
Yes.
So what I'm basically going to do is just give a rough overview on checkpoint inhibitors and the role of the gastroenterologist in identifying these. Jonathan is going to focus on managing the colitis aspect, which, as we have split the talk, is a talk on its own. Checkpoint inhibitors are part of a group of therapies called immunotherapies that have been harnessed to manage malignancy. It leverages the features of the immune system in order to attack neoplastic cells, where T cell targets are able to ramp up the immune system, focusing on these cells and inducing cell death. Adverse effects are then related to this hyperactive immune system, and they can mimic autoimmune disease. These are then termed immune-related adverse effects. So what you've got then is your T cells, firstly in the lymph node, where you have your cytotoxic T cell lymphocyte antigen present in terms of your antigen presenting cells, activating T cells, where you have your antigen presented and signaling occurring either to dampen down the immune response or upregulate the immune response. Malignant cells use their markers in order to try and evade the immune system, allowing for and dampening down this mechanism. This has therefore been harnessed now both with the CTLA-4 blockade and with the programmed cell death, both PD-L1, that's the ligand, and the PD receptor blockade in order to activate these cells. Here, for instance, the CTLA-4, right? You've got your checkpoint proteins, which under normal circumstances where you have the, sorry, I'm just moving my little talk screen, where you have both receptors active, the T cell is inactivated. But if this CTLA-4 is blocked, this activates the T cell once the antigen is being presented and results in tumor cell death. Similarly, with your programmed cell death ligand, this now acts more in the peripheral circulation, where you have the circulating T cells. Once they pick up the programmed cell death ligand and antigen, and they can assess if the tumor is foreign or part of the body. If this binds, the T cell does not activate. If it's blocked, either with an anti-PD-1 or anti-PD-1 ligand inhibitor, it results in cell death. 2011 was when the first PD-L1 was launched on the market, and that was specifically for the management of melanoma. Since then, multiple others have come on the market, and you have a diverse array of indications, including, recently the atezolizumab plus bevacizumab combination for treatment of hepatocellular carcinoma, which has excited us to no small measure. You have immune checkpoint inhibitors being prescribed as monotherapy or in combination with other immune checkpoint inhibitors, other chemotherapy, and other targeted agents. They're often still regarded as second-line therapy, but this is being challenged due to the success rates in management of most conditions. This is, for instance, management of metastatic melanoma. Up until 2005, this was a death sentence, with most individuals not making it to 3 years with stage 4 disease. Currently, however, almost 90% of patients are around it. I think this goes up to just under 24 months. But you can see this line being relatively flat, suggesting significant improvement. With such novel therapy and with upregulation of your immune system, as I've pointed out, come certain adverse effects. These are generally immune-related adverse effects, hence IRAE. The most frequently affected organs are in the highlighted boxes, and the ones contributing to the most fatalities are highlighted in bold, such as pneumonitis, hepatitis, myocarditis, and encephalitis. Immune-related adverse effects, risk factors in terms of high-risk conditions, existing severe connective tissue disease such as SLE, rheumatoid arthritis, and your inflammatory myopathies would obviously be a no. Uncontrolled vasculitis in individuals receiving combination, both CTLA-4 and PD-1 inhibition, would be naturally at risk for more adverse effects, and then dependent on the tumor biology. In terms of intermediate risk, type 1 diabetes, previously treated autoimmune disease such as autoimmune thyroid, celiac, and Behçet's, you can consider using these checkpoint inhibitors in these patients, as long as they're carefully monitored and are aware of increased risk of side effects. The side effects are generally somewhat time-related, with the earliest being your skin effects, which can occur anything from 2 to 3 weeks, followed by your GI and hepatic side effects at between 6 to 7 weeks from initiation, and finally your endocrinopathies, which can occur from 9 weeks, and then it somewhat persists. The endocrinopathy specifically can occur even once you've completed a course of therapy, and this should be taken into cognizance. Your time relation does vary from drug to drug. As you see up here, you've got ipilimumab, and down below nivolumab. And although the rough rule remains in terms of your dermatological manifestations occurring early, these can vary between patient to patient. Newer agents have been shown to have less side effects and can be used in patients such as smokers, where both your small cell and non-small cell lung cancer have been shown to, or these therapies have been shown to be quite effective with. but smoking is an additional risk factor, and there you can choose drugs that have less of a risk for pneumonitis, such as atazolizumab. In terms of your common adverse events, the dermatologic manifestation is a maculopapular rash, often with pruritus. It can blister and form bullous reactions. Your diarrhea and colitis, it can range from just simple diarrhea, less than 4 stools a day, all the way up to severe colitis with hematochezia and fever, mimicking an acute severe ulcerative colitis episode. Your liver manifestations is often asymptomatic and needs to be monitored. As with any drug, you can have mild elevations in your transaminases, but once jaundice sets in and elevations greater than 5 times upper limit of normal, you need to consider therapy. Pancreatic, an autoimmune pancreatitis can occur. And endocrine, a hypophysitis occurs. Hypophysitis is inflammation of the pituitary gland, and you can have headaches and visual disturbances due to mass effect on the optic chiasm, fatigue, altered consciousness, deranged electrolytes, specifically hyponatremia, anorexia, and mood changes. In terms of the management of these patients, it should be done in a multidisciplinary manner with specialists from the various affected organ systems involved. Management is generally based on the severity of symptoms, and supportive care is your first line. With relatively mild symptoms, consider holding the drug, but try and keep it going. It's often thought that when patients have these adverse effects, it's a sign of better antineoplastic effect from the drug. Moderate symptoms would necessitate holding the drug and redosing if the toxicity improves. Once you start hitting grade 3, that's when you should consider initiating steroids with these patients. Grade 4 is considered to be life-threatening, and grade 5 is fatal adverse events. So in terms of managing your skin manifestations, your maculopapular rash, your grading then, your grade 1, which would be papules covering less than 10% of your body, essentially topical therapy, and continue your immune therapy. Grade 2 then, which would be 10 to 30%, but not interfering with your activities of daily living. Consider holding the immune therapy and further supportive therapy. Prednisone can be considered, but once you start considering any immune suppressive agents, discuss this with the patient's oncologist, because any form of additional immune suppression may dampen the effect on potential in terms of severe, that's when your immune therapy definitely treat with high potency steroids. This is what your rash look like. This is your rash, maculopapular or even mobiliform appearance. A pneumonitis is to be taken seriously, and even with grade 1 changes, consider holding immunotherapy. Once you've got your CT chest and you've confirmed a pneumonitis, you hold immune therapy, and these patients are not necessarily to be re-challenged. Of course, it would necessitate you looking for any other causes of the pneumonia type picture in terms of your sputum culture, sputum blood culture, viral panels, and plus minus a bronchoscopy. In terms of your liver manifestations, grade 1, so less than 3 times upper limit of normal, continue your immune therapy. But if the lab trend continues on an upward trajectory, you can consider holding. Moderate would be elevations of 3 to 5, severe 5 to 20, and life-threatening greater than 20. These patients can be considered to start steroids once they're at grade 2. MMF can be considered in severe cases, but infliximab is not used for patients with hepatitis. The hypophysitis that I spoke about in terms of inflammation of your pituitary gland, as you can see here, your pituitary fossa fills up, and you can get a pressure effect on your CNS with your visual disturbances, headache, and hormonal disruption in terms of thyroid, adrenal, and electrolyte issues. Primary adrenal insufficiency is one of the manifestations. Consult endocrinology, start a corticosteroid on these patients, and they can be treated essentially as an adrenal insufficiency. If these patients settle and improve and have low-grade effects, immune therapy can be reconsidered in these patients. It's important to know about your adverse events. They're ever-expanding indications for these drugs, with more patients being initiated on them. We need to be aware of the time factors and the presence of more than one immune-related adverse event occurring in the same patient. They can occur at various times and at a time distant to the course of therapy. Multidisciplinary teams are important, with the gastroenterologist being a spoke and the patient's oncologist at the center of coordinating that approach. Your basis is supportive management. Your oncologist, like I said, is at the center of management. Severe cases do, however, require immune suppressive therapy in terms of dampening down that response. I'm going to hand over now to Jonathan, who's going to talk further around the management of the colitis associated with checkpoint inhibitors.
Hi, Jonathan.
Can you hear me?
Yeah.
Okay, brilliant. So I just wanted to say thanks, Bolon. I don't know if Chris, if I can launch straight in, or...
No, go ahead, and maybe we'll take questions afterwards. Jill will host that.
All right. So again, thanks, Bolon. I'm going to focus, obviously, as he said, specifically on the colitis aspect. Basically something that we're likely to see more and more often, and we'll get into that in a second why. This is obviously the slide that Bilal had put forward previously. Immune checkpoint inhibitor spectrum of affected organs is very large, and we're going to be focusing specifically on the colitis aspect. In terms of the colitis aspect, or diarrhea and colitis, which is distinguished in terms of how we look at it, how we potentially respond to it. But in terms of why we may be consulted as gastroenterologists, diarrhea is very common as an immune-related adverse event. Specifically, the earlier agents, the anti-CTL4 ipilimumab, which is still being used very frequently. The newer agents, the anti-PD-1 and the anti-PD-L1 ligand, lesser so. For different, obviously, indications which are expanding all the time, combination therapies are being used, and we're likely to see these numbers increasing. Interestingly, and Bilal alluded to this, the presence of these immune-related adverse events are commonly seen as independent predictors of improved survival from the primary cancer, regardless of which treatment is required. And there's some postulated reasons for that, and the microbiome may be implicated, and we'll get into that in a second or a little bit later. Just in terms of diarrhea and colitis, again, it's very common. It's the second most common after skin manifestations. It's probably, well, in the literature, it's the commonest reason for checkpoint inhibitor cessation. The earlier agents, as I said, the CTL4s are more common than the later agents. Combination therapy more common than monotherapy. The requirement to stop immunosuppression potentially indefinitely or completely is higher in the use of the anti-CTL4 therapies. In fact, a severe immune response requiring cessation of therapy and escalation of immunosuppressants or institution of immunosuppressants is a contraindication to reinstituting the CTL4 therapy, but in the PD-L1 or the PD-1s and the anti-PD-L1 agents, if patients respond, then cautiously reintroducing to treat the primary tumor is not contraindicated and is obviously necessary if patients put on it, for instance, for metastatic melanoma. Interestingly enough, time to resolution with these agents is variable. The average is between 1 and 5 weeks, but some patients may persist with grumbling type symptoms for months, irrespective of their initial response to treatment. There are some slight differences in expected time to onset of symptoms or adverse events with the different classes of immunotherapy. The anti-CTL4s are more predictable, and they were typically or classically seen as between 4 and 7 weeks, which is typically between the second and the third dose for the anti-CTL4. Whereas with the PD-1s and the PD-L1s, it's more variable. Maybe as early as after the first dose, a week or two after the first dose. And again, as Bilal had mentioned, it may be even years after cessation of therapy. So the index of suspicion for an immune-related adverse effect is not contemporaneous with the actual drug being used. If a patient's had a single dose of an immune checkpoint inhibitor and they present with profuse diarrhea or a colitis type picture, then you should have a high index of suspicion, in addition to obviously, a broad view, but this is part of the differential for cause. There are various sort of traditional risk factors, and I just want to take a step back and say, as I think we've alluded to, and I think instinctively, most of us don't necessarily have much experience with this because it's a very new field. There's a lot of different bits that are being worked out, prospective studies, retrospective reviews, case series that are being published, and then things taken forward. But most of the data for some of these factors is really only in the last 3 or 4 years. But despite that, there are more and more reviews that are being put out, and some of the sort of questions are being wrung out and coming out in these reviews. In terms of that, this was a fairly recent review looking at some risk factors for enterocolitis, or the colitis associated with these immune checkpoint inhibitors. Of interest was obviously, in terms of this talk and this part of the G-ECHO lecture series, is pre-existing IBD. And IBD patients are seen as, or seen in the literature as about 3 to 4 times more likely than a non-IBD patients to have these GI-related adverse effects. And we'll get into that a little bit later in the talk. Very interestingly enough, this microbiota association with both response to the immune checkpoint inhibitors and response to or risk for developing colitis. And there are some interesting reasons for that as well, which we'll get into later in this talk. So as Bilal had mentioned, the oncologists are obviously the drivers of using these agents, and we will likely be engaged when there's an effect on, in this instance, clearly the gastrointestinal tract. We have a different view or different way of looking at, for instance, colitis, but being able to sort of speak the same language and understand the same, factors is fundamentally important. And by convention, this common terminology criteria for adverse events is used with these immune checkpoint inhibitors. And this is from the US National Cancer Institute. This, again, convention of grading things from, grading events from 1 to 5 is right across all the different organs affected by the checkpoints. But it has some implications for us because it doesn't quite overlap. And just in terms of that, their definition of diarrhea is increased frequency of watery bowel movements, and colitis being objective evidence of inflammation of the colon. So in terms of the diarrhea and colitis aspects, this is the common terminology criteria. Grade 1 is considered mild, is typically treated as an outpatient, doesn't require extensive investigation. Grade 5 is obviously death, and where we're likely to get involved is, difficult to manage grade 1, and then certainly grade 2, 3, and 4. From a diarrhea perspective, 2 is increase of stool frequency 4 to 6 times above baseline, and 3 is greater than 7, typically requiring hospitalization and often escalation. And then colitis is obviously evidence of objective inflammation, mucus or blood and stool pain, or imaging abnormalities. What is a concern for gastroenterologists is that diarrhea is a poor indicator of endoscopic severity. And we know, extrapolating from the ulcerative colitis literature, that endoscopic severity is a prognostic factor, a major prognostic factor, both in terms of patients and their course, as well as choosing therapies, escalating earlier, and really managing the patient appropriately. And just on that point, this is an interesting table from one of the reviews from the British Society of Gastroenterology. And I just want to draw your attention to 2 things. So this is the common terminology criteria for diarrhea and colitis, and how it correlates with Mayo score. And then this, which I confess I don't have much experience with, this Lichtiger index, but it's essentially a modified Truelove and Witts score. Patients who are grade 2 by this common terminology typically have, by a Truelove and Witts score, greater than 6 loose stools per day, as well as, if it's colitis, evidence of potential toxicity. We would see these patients as sick, most likely the vast majority of them, and treat them, the vast majority of them, as acute severe ulcerative colitis patients. Whereas there are a good proportion of this under the common terminology definitions that would be underestimated. And that is a concern. And sort of alluding to that, or revealing that a little bit more, was this study correlating, well, in fact, looking at endoscopic appearances in patients who presented or who had endoscopy with a suspicion of immune checkpoint inhibitor colitis. And a good proportion of these patients, and these are different case series, and there's a discrepancy between them. Obviously, these were single centers, and their admission criteria were different, but a good percentage had extensive colitis. In this group, patients, specifically the second group, who were obviously a sicker cohort, patients who had, by the common terminology, grade 2 or grade 3 diarrhea, had virtually identical rates of treatment escalation. And that was, again, in this study, 68% versus 67% grade 2 and grade 3, or grade 3 and grade 2. So over 2/3 of patients who had grade 2 diarrhea severity by that common terminology ended up requiring escalation to anti-TNFs, again in that cohort. So I think the take-home message in terms of that is, as gastroenterologists, knowing what the endoscopic appearances are and using that to prognosticate is important, gives us important information and allows us to take things forward. Now, clearly not all diarrhea is colitis, and not all colitis is related to checkpoint inhibitors if the patient happens to have been on checkpoint inhibitors. So obviously excluding alternative diagnosis is important. Specifically, the patients who would be using or who would be on checkpoint inhibitors in this context may have diarrhea or evidence of colitis related to the primary cancer. They're immunosuppressed infection. They may have required radiation therapy. They're on multiple different agents, multiple different drugs, and those may have diarrhea commonly as a side effect. And then, of course, other immune-related adverse effects from the checkpoints may result in diarrhea, including the autoimmune thyroiditis. In terms of the workup, it would be fairly similar to a standard workup that a patient would have, that we would see commonly, to exclude infectious etiologies. I just wanted to make the point here that, again, endoscopy should be quite high up the algorithm, because if patients potentially have poor prognostic features, and in this case, that would be extensive disease or ulceration, similar to the ulcerative colitis view, or acute severe ulcerative colitis response, not delaying workup, so that if there is a need to escalate to biological therapies or step up therapies, that is not delayed. In terms of the use of fecal calprotectin to try and separate out patients for endoscopy, there's some overlap with the ulcerative colitis response, although we can't entirely extrapolate from ulcerative colitis literature. Again, I think the largest case series in terms of this was only 39 patients, and they had in that case series a mean of 465 micrograms per gram for ulcerations and 150 with normal endoscopies, but having microscopic inflammation. So using a cutoff of 150, which we often do use, gave a sensitivity of around 70% for ulceration and about 85% for microscopic inflammation. So not bad, but not amazing in terms of the negative predictive values, which were significantly less. In terms of imaging, CTs are useful. The commonest features in all of the case series is diffuse thickening of the bowel wall, is suggesting a pancolitis, although segmental disease is possible. The sensitivity for picking up colitis on this cross-sectional imaging was about 85% in the largest cohort that it came across, with a specificity of about 75%. And then just to talk about the role of endoscopy, as we mentioned, exclusion of concurrent or alternative diagnoses is fundamentally important. Early step up if there's poor prognostic features is anticipatory. The use of or the ability to get histology is fundamentally important. Microscopic colitis as a cause for symptoms is not uncommon, and that obviously changes your approach. It's only made on biopsy. There's a question mark around whether flexible sigmoidoscopy is adequate. In retrospective analyses, only about anywhere between 3 and 8% of patients who ultimately had a diagnosis of immune checkpoint inhibitor colitis had isolated right colon disease. But in about a quarter of the patients, 24% of patients who had pancolitis, the disease was worse on the right side compared to the left. So, the question of whether a full colonoscopy is necessary or not is an open question. In terms of doing gastroscopy at the same time, the recommendation generally is to only do a gastroscopy if there are upper GI symptoms, although there is an entity of, which is fairly rare, immune checkpoint inhibitor induced gastritis. The range of abnormalities is similar to IBD generally. anywhere from normal looking mucosa to an erythematous pancolitis to loss of vascular patterns, inflammatory exudates, erosions, ulcers, etc. The colitis is generally or typically on the mild to moderate end of the spectrum. Again, in looking at some of the data, Mayo 1 and Mayo 2 scoring on endoscopy was in about 60 to 70% of patients. There's a question of ileitis or isolated ileitis, and it hasn't been very well studied. The one case series that looked at that only had one case in 53 in their cohorts that had isolated ileitis. And in patients who had pancolitis with ileitis, there was evidence in some patients, but the selection criteria was also poor. Not every terminal ileum was intubated. So it's an open question in terms of that. The presence of ulcerations, though, did predict 30% steroid refractory disease. And so that, again, that's a poor prognostic feature and a place for early step up, a low threshold for considering escalating therapies. And just in terms of that, again, then the presence of rectal bleeding may be a potential marker of severe disease and a need to escalate from there. The histopathology is interesting, similar between the different kinds of checkpoint inhibitors, but different from ulcerative colitis, which would be generally, I think, as gastroenterologists, we look for corollaries because it looks like a similar kind of disease. But in fact, the inflammation is more acute. Cryptitis and cryptomicroabscesses atrophy and dropout as compared to the branching, distortion, basal lymphocytosis, and the panel cell metaplasia typically seen for the chronic colitis that we would need to make a UC diagnosis. In the patients where they have normal-looking colons endoscopically, but microscopic colitis is seen, it's a lymphocytic colitis invariably. So just to talk about goals of management, maybe I'll just go to this slide and then go backwards. There are a lot of algorithms that have been put out. They all virtually amount to the same thing. But the principle of management is dependent on grade. Grade 1 disease, if it was diarrhea less than 4 from baseline, less than 4 bowel movements from baseline, is typically, as I said, managed as an outpatient. Even early grade 2 in some of the oncological literature is treated similarly. And there's a concern about that with us as, again, gastroenterologists, because there's poor concordance between that grading and severity of mucosal inflammation. And this outpatient management is typically with holding the immune checkpoint inhibitor and using anti-motility agents. So potentially even high dose Imodium or even codeine phosphate. And as I've shown you that earlier graph, patients with an acute severe colitis to be put on constipating agents is considered verboten. So it may be, again, a lower index of suspicion for early endoscopy. But just the principles, and I know I'm jumping back and forth here, so I apologize for that. But the goal is obviously to sort out the symptoms, return a patient to a functional baseline, avoid complications, and as far as possible to get the patient back onto their baseline therapy, which was indicated for the treatment of cancer. Now, in terms of where we would get involved, again, that would most likely be in grades 2, grade 3, and grade 4. Grade 2 patients are characteristically treated as outpatients with oral steroids. The checkpoint inhibitor is held and diagnostic evaluations performed. Grade 3 patients are sick, and grade 4 patients by definition have life-threatening potential complications. So those are clearly inpatients. Grade 3 and grade 4 patients would be on intravenous IV corticosteroids, which is well, in grade 2, grade 3, and grade 4, the first-line treatment similar to ulcerative colitis. There was a discussion again in the literature about trialing budesonide in patients who are high risk. especially with the anti-CTL4s, which have a higher rate of bowel inflammation. But there was no clear clinical benefits to that in those patients. So just to reaffirm that the early initiation of systemic corticosteroids is the foundation of management in these patients. And that most patients who present with diarrhea will need corticosteroid treatment. In sort of two large cohort studies, the one was 117 patients, the other one 87, it was 68% and 60% of patients required corticosteroids. Now there's concern obviously around immunocompromising these patients further who are immunocompromised at baseline, they're cancer patients, they're on other therapies. And the question of prophylaxis, for instance, for PCP and other infectious diseases has been put out there in the literature, although it's poorly studied and there's no clear advice in terms of that. The question of stepping up with patients is extrapolated from the UC experience with a view to give 72 hours to see if there's been a clinical response, but there is no day 3 criteria that's been prospectively validated. So in terms of the IV medications, the use of methylprednisolone or IV hydrocortisone in equivalent doses is again similar to the UC literature advised. And then really, again, similar to UC, on day 3, patients are either getting better or they're getting worse. In terms of how we know patients are getting better or not getting better or getting worse, there is no validated criteria, and we extrapolate it. If patients are improving and their common terminology, grade is downgrading, then that would be considered clinical response. We would potentially use UC criteria by extrapolating it, or these simple clinical colitis activity index scores. If patients are improving, we would transfer to oral corticosteroids and taper over 6 to 8 weeks, and that would essentially be the end of the story. And they're, depending on the agent, reintroducing the immune checkpoint inhibitor for the anti-cancer effects would be up to the oncologist. Patients who've had a poor clinical response, hopefully we would potentially have picked those up early and initiated the pre-biologic screening, and then escalated from there. So the best studied step-up therapy is the anti-TNF infliximab, and that's limited dosing, typically 3 doses at entry point 2 weeks and 6 weeks. The response rates are very good, considered to be above 80%. There are outstanding questions, especially in obviously more severe patients, about accelerated dosing schedules, higher doses at the beginning, additional doses in the first 2 weeks, and therapeutic drug monitoring. And these are open questions. And a lot of it's, the management of this is presently, I think, on institutional best practice rather than on good data. There are alternatives, and vedolizumab may actually replace infliximab in future with better studies as we go forward, because as vedolizumab doesn't interfere with the efficacy of the immune checkpoint inhibitor therapy by immunosuppression, it might be an especially attractive option. Similar response rates to infliximab in there's not great data. This is probably the major one that was put forward. And then just to talk about other modalities, this is all very case series parts of the literature. There are no great big or even large prospective trials in terms of this, but what has been used is MMF and tacrolimus. A discussion around an alternative anti-TNF in patients who've had infliximab infusion reactions is theoretical, but it has been used in some centers. Use of fecal microbial transplantation is obviously very interesting, and anything that involves the microbiome is very interesting and sexy. But it's also very much case reports in the literature. There have been successful inductions of remissions, if I can say that, with FMT in patients who've been refractory, but it's in the 1s and 2s and 3s. And then patients who require surgery, it's obviously a very bad state. Patients who are on checkpoint inhibitors in the first place are clearly cancer patients. And there would be a need to assess basically the patient's general functional status and prognosis. There's no place for considering pouches and 2 or 3 stage procedures. The surgery in this context would be a subtotal colectomy and ileostomy. Just to talk about patients who've got symptoms, normal scopes, and inflammation on biopsies, it appears that the microscopic colitis is, in this context, is more aggressive than run-of-the-mill normal microscopic colitis that we'd be used to seeing. And the use of higher end therapies, infliximab, vedolizumab, is much higher, obviously, than the average microscopic colitis that we see. Although the use of budesonide rather than prednisone in the grade 2 group here has shown some positive effect. And then just a question of relapsing. Again, data is sparse. The largest retrospective view of this was probably this study with a relapse rate of about a quarter of patients. The view would be to reintroduce at the last effective dose if the patient relapses while weaning steroid, to taper more slowly, and then, if that's unsuccessful, to consider escalation. Patients who've had an initial response and then relapse may need to be, or should probably be, re-investigated for the development of infectious etiology, specifically CMV in this context. These patients are profoundly immunosuppressed. And then the question of reintroducing the checkpoint inhibitor is obviously from the oncologist side, but reassuringly, about 80% of patients are symptom-free at 3 months, and patients who were initially on the anti-PD-1 or the anti-PD-L1 would be reintroduced by guideline, for the most part, if there wasn't a reason not to, by the oncologist. And interestingly enough, the risk of recurrent GI immune-related adverse effects after introduction is low. The data, again, is sparse, but 90% of patients had no recurrence after 3 months in one of the large cohorts. And then it wouldn't be a gastroenterology talk without talking about the microbiome. It's very interesting, and it has been noted both in animal models and then in this paper in humans, that there is a microbiome signature for response to immune checkpoint inhibitors. And this is a bit of a messy slide. I don't want you to worry too much about it, but just to point out 2 things. So this is the anti-CTL1s up at the top, the responders and the non-responders, and the anti-PD-1, the responders and the non-responders. And in both groups, the responders typically had the Firmicutes microbiome phenotype. And in the non-responders, they had low numbers of Firmicutes and increase of the Bacteroidetes. So those were considered signatures or signals for potential response. And interestingly enough, on this chart, and these are just different cohorts, this is basically what I said before. Bacteria associated with anti-tumor response was the Firmicutes in these groups, and with non-response, the Bacteroidetes. But the bacteria associated with the GI immune-related adverse effects were the Firmicutes. So this correlation between patients who are responding, or their primary tumors responding to treatment by the immune checkpoint inhibitors, and their rates of adverse effects is certainly being seen. And it's so much so that it's considered a positive predictive feature for actually cancer response or cancer remission. And as a result, the oncologists actually, I don't want to say that they like the immune-related adverse effect, but it doesn't seem to be any other such strong associations with any of the other organ-specific immune-related adverse effects. And then just to talk about patients who've had preceding IBD, who are then put on immune checkpoint inhibitors. Now that scenario is likely to happen more and more frequently, both because we're using checkpoint inhibitors more commonly, and also IBD-related cancers are within the realm of immune checkpoint therapies. There is this increased risk of adverse events, as we mentioned, about 3 to 4 times. And there's an increased risk of IBD relapse when you're putting patients on immune checkpoint inhibitors. Again, data very small, mostly case series. But interestingly enough, when patients flare from an IBD perspective when they're on checkpoint inhibitors, they don't appear to have a worse clinical response to escalation in therapies to matched cohorts. And when they, the opposite of that is also true. Although their risk of adverse events is worse, step-up therapies do not seem to be inferior. This question of prophylactic therapies on re-challenging hasn't been tested. 5-ASAs, there's nothing in the literature, and the use of, apologies for the misspell, budesonide, also not prospectively looked at. But the key point here is that IBD is not a contraindication to the use of appropriate anti-cancer therapies. So patient must get what they need. And this is my last slide before the summary. Really comes down just to this question. I think when we first encountered this topic, this question was really out here. Is immune checkpoint inhibitor associated colitis the same as ulcerative colitis, reviewed the same, managed the same, and taken forward? And the answer is a definitive no, although there are obviously corollaries, and we have a sort of a superstructure to deal with these kinds of, or an instinct to deal with these kinds of issues, although that's in the absence of data, and hopefully those will fill in the gaps. There was this nice paper that was very recently published that actually looked at the cell types or the immune response and matched it against patients with UC, and the predominant cell type is different. And I mean, we've also seen that, of course, with the histopathology. And then, so just in summary, really just these 5 or 6 key points, 6 or 7. The gut is frequently affected, and it's going to engage us. Anti-CTL4s and anti-PD1s and PD-L1s behave slightly differently, and it's important to know that. We are using this common terminology to guide management, although not entirely so, because it may underestimate severity. Standard treatment is use of systemic corticosteroids, and the early initiation of that is important. We should prognosticate when we can, and the use of endoscopy is helpful for doing that. And rapidly transitioning to step-up therapies is important. And then again, onto the first point on that slide, we should be prepared to see this more, manage this more, and be more comfortable with it going forward. And that's it. Thank you.
Okay. Thanks very much, Bilal and Jonathan. Those are great talks. So we've got a bit of time for some questions. So Bilal, I'm going to start with you. This is actually possibly more of a comment than a question. It reads, is it fair to refer to the pituitary dysfunction as secondary and not primary if it's due to the medication?
Yeah, I suppose that is a fair comment. It's directly related to T-cell infiltration of the pituitary and dysfunction as a result of that. So I take that as a fair comment, yes.
Absolutely. And then a second question, in IBD, we're starting to use combinations of different biologics. Do the oncologists have a similar approach with the inhibitors, where they're combining, say, CTLA4 and a PD1? And if they do, is that associated with a higher risk of side effects?
I can answer that. Yeah, so absolutely, they are definitely moving in that direction, and we are seeing higher rates than either the CTLA4, which is more than the PD1 and the PD-L1s. Combination therapies are becoming first-line management for, obviously, the specific individual cancers. And those are associated with greater adverse events. So we will, as a consequence of that, be engaged more and more often.
And then just in terms of the inhibitors, I mean, I think you've alluded to that ipilimumab much higher risk of adverse events than the PD-1 inhibitors like Keytruda. Is there a reason for that?
There is likely to be a mechanistic reason, but I'm not aware of any specifics. Maybe Bilal has an answer for that. It's obviously observational, but I haven't seen a postulated reason for that. Yeah, I wish I could.
Can you comment on that, Bilal? Okay, Jonathan, another question. Is CT scan better than MRE?
So, I mean, the use of a CT scan in these patients is often patients who are presenting with a non-specific or undifferentiated colitis. This is mostly a colitis. So small bowel imaging in this context is not primary. And, you know, patients who are from the common terminology 3 and specifically 4 may have, you know, complications, and picking that up is key. So perforation, toxic megacolon, you know, etc. So, I mean, the use of MRE in these patients certainly hasn't been, well, one, validated, and it's certainly not in the algorithm. But I think plausibly, I wouldn't see where it would have an increased role or a better role.
Absolutely. And then just another question is, how can MMF be considered a therapy when it's also a cause of colitis?
I mean, it's a cause of colitis, but that would be an adverse effect. In these patients, it's you know, refractory disease or inability to get or acquire infliximab, and these patients need, you know, step up immunosuppression. So again, these are case reports. These are not you know, prospective multi-center guideline-based recommendations. They have been used, and they have had a you know, there is evidence of benefit. But you know, where you have the ability to provide therapy, you would want to go with the evidence, and it would never be put before infliximab and vedolizumab, where that seems to be the you know, the preponderance of data.
Well, we see the same in terms of the anti-TNFs, where you can get a paradoxical colitis in patients who put on an anti-TNF for another perhaps rheumatological condition. Then just sort of final 2 questions. So malignant melanoma is probably the only tumor which is considered a real contraindication to anti-TNFs, but obviously it's used in these severe cases. Any comments on that? It probably isn't much more than a comment.
I mean, I don't know if Bilal can, but and I'm not basing something in the literature, but just I'm sure from people's personal experience, the you know, the colitis at the point where you are introducing these agents is potentially life-threatening. The use of the anti-TNF is short, is for a short course. It's 2 or 3 doses. It's not continuous. And the oncologists, and this is anecdotal, this is from experience, but are very, very keen to clearly treat the life-threatening issue up front and then take things forward. So it isn't considered a contraindication at all. Yeah, I don't know if Bilal wants to add anything there.
Jill, it's just in my experience of, you know, I think I've had 3 of these patients with checkpoint inhibitor adverse effects. The patient with a metastatic malignant melanoma with a colitis, we actually managed him with vedolizumab, and he had a great response.
Okay, interesting. Yeah, it's unfortunately not something in state practice I'm really ever probably going to see much of, because they cost in excess of R1 million. So it's limited for Grooteskiel Hospital at any rate. So I think we've run out of time, so I think it's time to close the meeting. Is you happy if I do that?
Of course.
Okay, so a very big thank you to both of our speakers, Jonathan and Bilal. That's fantastic talks. We all learned a lot. I'd also just like to thank ECHO University of New Mexico, as well as the ECHO India team. Please fill in feedback forms that are available on the chat, and also the recordings of these will be available on the Gastro Foundation website. And also thanks, of course, to Karen and Cheryl, who put this all together on a weekly basis. And finally, just a reminder that next week's GECO is related to hepatocellular carcinoma. So thanks everybody for joining, and have a good evening, and we'll see you next week.
Thanks very much.
Thank you.
Thank you.
Thanks, Jonathan.
Yes.